Okay, today we're going to talk about post-op blood loss and surgical site bleeding. So the first thing you want to know when you get the call saying, hey, my patient's bleeding is what do you want to ask? So first things you want to know are what surgery did they have and when was it? What are their comorbidities? Do they have any reason to be on blood thinners? Are they on do they have AFib? Are they on stents, etc.? What have you tried to do for it so far? A lot of times the nurses will call and say, hey, my patient's bleeding. They're soaking through their dressings. Can you come up and see them? You say, well, what have you done for it? And they say nothing. So then you need to do something. You want to know what their vital signs are: blood pressure, heart rate, if they've been making any urine, etc. Do they have a Foley in? Is important. And then you want to know what things you can do. So obviously go see the patient. Anytime you get a post-op patient who's bleeding, you need to go see him. You can tell the nurse to get some labs while you're on your way up there, get a CBC, an INR. Have they been typing cross recently? Have they been typing screened recently? You have about 3 days that a type and cross will last before they need that to be redrawn. And then what things can you do? Do they need a Foley? What kind of IV access do they have? Do they have a 22 gauge in their right hand, or do they have, an introducer in their IJ? These are important things to know. So you go up and you want to know, what's it look like? Is this some nonstop big bleeder that's just soaking through ABDs instantly, or is it just some ooze that's kind of venous appearing and just kind of unrelenting? So try easy things first. Obviously, the first thing you want to do is direct pressure. This doesn't mean taking your whole hand and placing it over top of the dressing. This means one or two fingers pressing hard, hard enough to cause a little bit of pain, right over the site for about 10 minutes without peeking. You can tell the nurse to do it, but oftentimes they'll do it for 2 minutes. They'll say, hey, it stopped. And then they'll let go, and then it'll start back up. Is it still bleeding? So consider maybe some other adjuncts. What can you do? Well, we know how to stitch things, so we can put a stitch in it. We have some handheld cautery devices down in the ED. They don't work very well. Topical chemostatic agents like Surgicel or QuikClot. There's silver nitrate sticks. You can try these things. Sometimes if it's like a scalp bleeder from like a cranie patient, I've injected some local with some epi just into that area, and that seems to control the bleeding as well. So they're bleeding enough to the point where you get your CBC back and you think you need to transfuse them. What kind of products do they need? Bleeding patients need blood. Um, Early post-op bleeding transfusion products could be, packed red cells. TXA is good for early post-op bleeding. FFP, platelets, cryo, etc. This is more kind of massive transfusion protocol if you're starting to give all of this stuff. And if that's the case, then they probably need to be going back to the OR. But just for packed red cells, you expect to see a 1 gram bump in their hemoglobin for every unit that you give. Hematocrit should rise by about 3%. We don't care so much about the hematocrit. No one's ever going to ask you what it did, but hemoglobin is what we look at. If you're giving blood, you should be running it by your senior and your attending and keeping them in the loop. This is not something that you should be doing on your own as an intern without running it by someone first. I've made that mistake. TXA, so good for early post-op bleeding. From our trauma scenarios and literature, what we do is we give 1 gram bolus, followed by another gram over 8 hours. Fresh frozen plasma, this is what we give to reverse people's INR if they don't have any heart failure or they don't need to go emergently to the operating room. The other agent that we can give would be Kcentra if they had a super therapeutic INR and needed an emergency operation. But you want to know if they have heart failure because we need to be volume sensitive. FFP has a fair amount of volume in it to reverse INR. Platelets, you get one pooled pack of platelets. Cryo, really probably not something you're going to give in a post-operative bleeding patient, but good to know about. The goal, obviously, anytime you're giving any products is to be 1-to-1-to-1 ratio. But if they're bleeding to the point where they need to be getting kind of massive transfusion, they probably need to be going back to the OR. So you see your patient, and the most important thing of all about the post-op patient who's got some surgical site bleeding or some post-op blood loss is going to be what their exam is like. What do they look like? Are they pale, diaphoretic, altered, confused, angry, or are they chilling up there, texting on their phone, watching TV, or sleeping? These can cue you in onto what may be the most appropriate next maneuvers. And then what's their physical exam? Are they having pain? Is it new pain? Do they have any bruising? Is their abdominal exam, are they tender? Are they peritonitic? These are things you need to be looking at. Overall, if a patient is early post-op and requiring aggressive blood transfusions, they likely need to go back to the OR. Always keep in mind in the back of your pocket that if someone is bleeding, you need to stop the bleeding. It's the first tenet of surgery. So, hope this is helpful for you, and good luck being an intern.